to the RowanSOM Alumni Association's monthly webinar series. I'm Dr. Tom Cavalieri, the Dean of Rowan University School of Osteopathic Medicine, and we are very pleased to bring to you this next session of our alumni webinar series. This evening, we will explore the importance of health screening during the time of COVID-19. With the year that we have all endured and the great health concerns that COVID-19 brings, it's easy to defer or put off some important preventative healthcare tests and screenings. Tonight, we'll examine this topic. We'll discuss the importance of keeping up with annual health screenings in a safe healthcare environment and the possible ramifications of delaying health maintenance. We'll explore what the ramifications of many of the delays that we have been experiencing nationwide in physician visits, in delaying health maintenance, interventions to keep us well. We hope our attendees leave tonight's talk with gained importance and guidance about maintaining health and the health of your patients during this extraordinary time. The format of this webinar series will include a moderated panel followed by Q&A from our attendees, all within approximately 1 hour. As a reminder, you may submit your questions at any time in the chat so they can be shared with the panelists during the session. It's now my pleasure to introduce our presenters, all of whom are graduates of our school, of our alumni. They're our alumni, and as I always say, the best evidence of the success of any school is seen in their graduates. And I'm sure you'll agree when you hear all of our grads speaking tonight that we are a very, very successful school. First, Dr. Virginia Phipps. She is a RowanSOM class of 2000 graduate, internal medicine trained physician. She currently serves as a hospitalist as part of the COVID crisis coverage at University Medical Center in Lubbock, Texas. Dr. Phipps, who is a member of our Young Alumni Engagement Committee, will serve as our moderator for tonight's discussion. Also with us is Dr. Cary Mantell. Cary is a 1983 graduate of our school, is a gynecologist with the Robert Wood Johnson Center for Women's Health in Hamilton, New Jersey. He is a past president of our alumni board, and he's a current board member and does very much for us. Dr. Stewart Rich was a member of our Department of Medicine, Division of GI, a graduate of our school in 1991. He is double board certified. He serves as a gastroenterologist as the Beaufort Memorial Hospital in Low Country Medical Group in Beaufort, South Carolina. Rich has served as a faculty member here at SOM for a few years before he moved to South Carolina. Proud of all of you and grateful for you being part of this session tonight. I also would like to introduce student Dr. Ekrem Cetinkaya, the president of RowanSOM class of 2024, who will assist today's program. He's one of our amazing students that make us so proud. And I have to tell you, our grads, our alumni here, we are running the Rowan University COVID-19 Vaccination Center. We are vaccinating about 500 individuals a day. This is called Operation Save Lives. It is amazingly successful. But I mention it here because our students are the key to the success here. They're volunteering, they're engaged, they're treating every patient with utmost respect, compassion, and the impact that they are having on the community is amazing. So I'm proud of them and wanted to share that with you, because I know as our alumni, you're very concerned about our students and like to hear the great things they're doing. So with that, I want to also thank our SOM Alumni Webinar Advisory Board, our SOM team and alumni engagement and advancement for producing tonight's program. And I'll end by thanking Dr. Phipps, Mantell, Stewart, again, student Dr. Cetinkaya. I thank you for lending your time, expertise tonight. I'll now hand this program off to our moderator, Dr. Virginia Phipps. Thank you all again.
Good evening, all. It is my pleasure to be amongst all my esteemed colleagues. I am honored to be asked to moderate this program tonight, and I am grateful for Dean Cavallari, Dean Machichi, and for Gail Foreman for inviting me along for this amazing ride, and I appreciate the entire board for putting this program together. So we're going to be talking about the importance of screening during this time of COVID-19. And I know many people out there, because I've experienced this, are very concerned about going into the doctor's office to be examined at this time. However, there are protections in place for screening incoming patients for symptoms of COVID and safely having them navigate the clinic without significant possibility of harm. So if I can get the next slide, please. So a typical annual screening involves a head-to-toe exam, and that literally means a head-to-toe exam. As an internist, I definitely look at the head, the ears, the eyes, nose, mouth, all the important things that we need to see to make sure that you are healthy. Now, there's certain age-appropriate and gender-appropriate screenings that are necessary and some that are not necessary. Now, and I said head to toe mean everything gets examined. Your lungs get auscultated, your abdomen gets percussed and auscultated and felt on. We're looking for things like an enlarged liver, an enlarged spleen, any tenderness that may be there. We listen to the lungs. We examine the motion of the upper and lower extremities. We check your pulses. And for females, we also try to include a clinical breast exam if they wish. This is an exam that is also done by the GYN. So we give them the choice of having it done with us as the internist or family medicine doctor, or we refer them back to their GYNs. Now, there's also age-appropriate GYN exams, and that is typically recommended to start around the age of 20 and above. And these sources are the United States Preventative Task Force and the CDC. Those are my two sources for everything that's on these slides. Now, in the past, it was recommended that men be checked for testicular cancer up to the age of 40. However, this is no longer recommended. If there is a problem with the male testicles, they will let us know, and then we will initiate any evaluation that's necessary. If you're diabetic, you get a diabetic foot exam that includes looking between the toes, checking the pulses, tapping to make sure that you can feel that tapping, you don't have a loss of sensation, because diabetes over time can impact, impair, destroy the fine vessels that go down to the feet and subsequently damage nerves. Then there's also a microfilament exam, which is a little tiny tool, looks like a little toothpick that we use to check your sensation or the ability to feel. Because with diabetes, you tend to lose the feeling in your feet, resulting in ulcers that appear when you start having pain, and the ulcer has already gone through multiple levels of tissue. So we try to do this exam annually to prevent that poor outcome. Now, as part of the annual screening, we also do a depression screen, and depression has become well, let me just say this, depression and anxiety have become significantly increased during this time of COVID. So it's definitely important that you have one of those done. And this screen starts with 2 questions, and it's called a PH2, right? And it evaluates whether or not you have a depressed mood and whether or not you have sadness that you can overcome. That's called anhedonia. We assess for those 2 things, and if you answer positively if you want to both, we go on to a PH9, which is 9 questions to screen your degree of depression. As part of your screening, and this is also very important because the mood has changed significantly during this time of COVID, we go into asking about intimate partner violence. And that's extremely important because when people get depressed and people's moods are changing, they start using more alcohol, and then you have a problem with hitting or verbal abuse or any of those things are considered intimate partner violence. So we evaluate you for that. And then next is the alcohol screen, extremely important. How much do you drink? Do you drink every day? Have people expressed concern about your drinking? All part of an annual health screen. And then we get to tobacco use. We ask, well, I see patients 18 and above, so everyone gets asked this question: do you smoke? If you do smoke, how much do you smoke? Etc. And that triggers me to do another step, which I'm going to talk about a little bit later. Next slide. Okay, and then of course there's the blood pressure screen. This is a necessary screen from 18 years old to death. We screen everyone for blood pressure because people can have elevated blood pressures without having any symptoms at all. So it's extremely important that this is checked at least once a year. It will be checked more often if you are diagnosed with elevated blood pressure, or high blood pressure, which is designated as a top number, systolic blood pressure of 130, and a bottom number, or diastolic blood pressure of 80. It is no longer the 140/90. So when you go to see your doctor, make sure that you know what your blood pressures are. Okay, and then as part of your annual health screening, and once you're already in the clinic, you're already proven to be asymptomatic from possibly COVID, you can get labs done in that clinic setting, or you're sent out to another facility for blood tests. And the typical annual labs for the average person is a CMP, which is a complete metabolic profile, and fasting lipids. Fasting lipids means that you haven't eaten anything 8 to 12 hours prior to coming to the doctor's office. So those are the typical 2 sets of labs that are ordered from anyone coming into the office for physical from 18 years old to 110, if that's what they are. Now, the second lab here, the A1C, which is a hemoglobin A1C, which is a test that we use to diagnose diabetes or manage diabetes. That test is usually part of an annual exam, and if you're diagnosed with diabetes, you get it done a little bit more frequently than that, usually every 3 months. Now, a PSA is a test done in men. It's a prostate-specific antigen, and this is a test that's used to determine whether or not your prostate has a problem. And keep in mind, an elevated or a high PSA doesn't necessarily mean prostate cancer. Just means that there's a problem that may need further evaluation. Okay, no longer are we doing the rectal exam. There's no finger up the rectum anymore. If there's a need for that, if the PSA is elevated and there's a concern that there could be prostate cancer, we refer you to a specialist. A PSA is done typically in men 40 and above. Okay, at 24, you're not going to get a PSA. The current recommendation is PSA annually, 40 years old and above. Okay. Then there's the spot protein creatinine. Again, that's only for diabetics. And this is a urine test that we check a protein level and a creatinine level. And the creatinine is a function of how well your kidneys are doing. And that test is done as part of their screening. It's not done for everyone, unless you have a specific problem that we're aware of. A urinalysis is not a typical test annually. However, for any physicians taking care of pregnant female, that is usually included to detect any asymptomatic bacteriuria, which means that there's certain bacteria that's in your urine that doesn't cause any symptoms, but can cause symptoms to the unborn child. So that's an important test to do for that population. And of course, if you come in and have symptoms at the time of your screening, that becomes a necessary test at that time. Okay, and then the next test is GC chlamydia screen. Now, GC means gonorrhea, and chlamydia is chlamydia. They're both bacteria that cause bad symptoms if undiagnosed. Bad symptoms meaning if women between the ages of 15 and 24, typically those are the ages that are recommended for screening. 15 to 24, if they come in, they get screened because if you don't detect it, it can cause infertility in females. So that's an important thing to do. And of note, the CDC has reported that gonorrhea, chlamydia is the fastest rising sexually transmitted disease in that particular age group, 15 to 24. Now, hepatitis C, I put them both together, but I'm going to talk about hepatitis C by itself right now. Hepatitis C has been recommended to be screened in patients 18 to 79 per USPTF. Now, and this recommendation was made in March of 2020, so since it's the most recent, it's the one that I would recommend following. The CDC did have a recommendation of screening all persons born 1945 to 1965, but that's from 2012. So I guess you and your primary care provider will have to determine what's the best thing for you. And HIV screening is done in those high-risk patients, typically patients coming in with a complaint of symptoms consistent with a sexually transmitted disease would definitely get an HIV test. If you are exhibiting any high-risk behaviors, such as men having sex with men, you're going to be screened for HIV, or any other high-risk behavior such as drug use, you'll be screened for HIV. Next slide. Now, radiologic tests, they're not all annual screens, but the mammogram is recommended biannually by the USPTF starting at age 50 until age 74. Now, screenings can be started sooner, as early as age 40, but that's a discussion that you have to have with yourself and your primary care provider to determine family history, potential risk factors, etc., to start screening earlier. Now, a DEXA scan is started in females mostly. I mean, men can have it too, but it has to be very specific reasons for that. But it's typically a test done in females and usually starts at age 65. And then depending upon what's found, that'll determine the interval of screening thereafter. Now, colonoscopies. These are started at age 50, but Dr. Stewart, I think it's Dr. Stewart, will go further into what populations are screened when and why. Then as part of annual health screenings, this low-dose CAT scan of the chest. Oh, I'm sorry. I did not say what a DEXA scan was. A DEXA scan is a bone scan to determine whether or not you have bone loss called osteoporosis. So that's only done when you get older. And the low-dose CAT scan of the chest is only for tobacco users. And this is a recommendation for active tobacco users, and this can be done at any age as long as you're an active tobacco user. And this is screening for lung cancer. And then this last one I put on here, and it's not something that's done for the majority of patients that I'll see. It's a one-time screening test, and it's an ultrasound of the abdomen to determine whether or not you have an aneurysm. And the AAA means abdominal aortic aneurysm. And this is typically done one time in older men around 70, I think it's 74, that this test is done. Now, under special considerations I have here, consider aspirin. And this is only in certain populations. In high-risk individuals for coronary artery disease, and for those who are high risk for colon cancer. And I'm not sure, again, if Dr. Stewart is going to mention anything about that, but that's a recommendation that is discussed between you and your provider to determine if you have a need for that medication. Okay, and then we have eye exams. Now, typically, I recommend that people should get eye exams when they're younger. There's a recommendation for pediatric eye exams, but since I'm not a pediatrician, I won't mention anything about that. I am an internist, and anyone coming to me at age 18, I always recommend their first eye exam to be done then. And then it can be done every 2 years thereafter if they have no problem, sometimes even as far out as every 3 years. Now, is that a necessary intervention right now in the time of COVID? Many of these things are not, within a few months, it won't cause harm. However, if you have an abnormal mammogram and you've had a previously abnormal mammogram, I would suggest that you make the time to go and have that follow-up mammogram at 6 months if that's a recommendation. If you have an abnormal colonoscopy, I do recommend that you follow the guidelines of the gastroenterologist to follow up and not let. Somebody just asked a question and I couldn't read it, but I guess we'll get to it at the end. So follow the recommendations of your gastroenterologist because there are different patient populations that require colonoscopy more frequently than the average person, which is if it's normal every 10 years, but he will get into that later. And PrEP. What is PrEP? Pre-exposure prophylaxis. And this is for high-risk populations. Again, men who have sex with men, people who are active drug users and having random sexual encounters. Very important to consider PrEP, which is initiation of a one-agent medication to prevent HIV. That's what that means. And I think I went backwards a little bit because I forgot to say that. But the eye exam is once every 1 to 3 years. If you have no problems, it's going to be more frequently. If you're diabetic, it's once a year at least, sometimes more often than that, depending on if you have any disease in the eyes. And then dental exam is very important, especially if you have symptoms. Please go see your dentist. COVID should not prevent you from following up for acute care. However, outside of having a problem, every 6 months is necessary for proper evaluation and cleanings. And if you're a little bit nervous about going to the dentist during COVID, you can push it back to 1 year. I think that's appropriate. And if you have a problem, definitely discuss that with your primary care provider so that they can give you some guidance about following up with the dentist. I think I've covered most of the important issues regarding screenings. Keep in mind that all screenings is not for everyone. There's specific patient populations that some of these screenings are for. So I will now start my moderator duties. So I'm going to pose the first question to Dr. Stewart.
Dr. Phipps, before you do you want to take some questions? I had some questions that came in through the chat.
Oh, okay. Hi, everyone. This is student Dr. Ekrem. Can't remember his last name.
Cetinkaya. It's all good.
Okay, great. Thank you.
So some questions that came in were, how often should a CBC with DIF and total vitamin D be checked?
Well, a CBC is done most times as a part of the screening test. And that just monitors your hemoglobin, hematocrit, your white blood cell count, your red blood cell count. And that can be done once a year unless you have a problem. I mean, keep in mind that most females will tend to be anemic if they're menstruating. If you're anemic post-menopause, then we tend to look at that a little further because there may be a problem that will require that you have other testing done and possibly see a gastroenterologist to determine where the source of blood is coming from. But it depends on what we see. And again, once a year is more than adequate. Now, a vitamin D level, that's also a troublesome concern for most insurance companies. But I check a level if a patient has specific complaints about pain, arthritis, those types of things, I would do a vitamin D level. Or if I see something on exam that's a little bit concerning and I require testing for vitamin levels. But it's not typically a part of a vitamin D, of an annual exam panel.
Perfect. Thank you so much. Yep.
Okay. All right. So moving on. Dr. Stewart, so nice to meet you finally.
Thank you. Likewise.
Yes. So the first question I have for you is, could you briefly review the most current guidelines for colorectal cancer screening?
Certainly. First of all, thank you again for having me here, and thank you, Dr. Phipps, for heading this up. I'm going to start out with my least favorite slide here, but basically when patients present to us or they present from their primary care physician, we try to separate them into two groups, patients who are average risk for colon polyps and colon cancer and patients who are at increased risk. So not all these bullets here are patients that are necessarily at increased risk, but certainly the first two, patients who have a family history of colorectal cancer, and we're talking about family members, first-degree family members, or two second-degree family members with colorectal cancer that were diagnosed before the age of 60 usually. Same thing for family members with adenomas. Now, we don't always know our family history or a patient's family history, but if a patient knows that their parents or siblings have had significant adenomas, multiple adenomas, or adenomas that are greater than a centimeter, like I said, we don't always know that, but if that's the case, then they are at an increased risk. These other bullets in the middle here, I only threw those in because oftentimes when we do colonoscopies on patients, after we get them in the recovery room and we have to tell them that we removed polyps, one of the most common questions I get is, well, why did I develop polyps? I don't have a family history. I don't have any symptoms. And the explanation is usually, well, you may have inherited a genetic predisposition, or there are certain things in the environment that we think are at play, such as cigarette smoking, unhealthy lifestyles, obesity, gallbladder removal is a little questionable, but basically unhealthy lifestyles. Other things that are risks, but not necessarily that you have to screen them sooner, are patients that have had radiation. We know that patients that have had radiation for prostate cancer have an increased risk of rectal polyps and rectal neoplasia. Also, patients that have a history of other cancers, such as uterine cancer, ovarian cancer before the age of 50. Obviously, we worry about those patients and also possibly having another syndrome like Lynch syndrome or a genetic syndrome that predisposes them. A definite high-risk community are patients that have a history of inflammatory bowel disease that involves the colon, patients with ulcerative colitis or Crohn's colitis. Most of those are in our practice, and we have to follow those patients pretty close after a certain period of time, 8 to 10 years. After they've been diagnosed, they need to be screened every 1 to 2 years for neoplasia, and theirs acts a little bit differently. And I'll talk a little bit about African American race in another slide. So if we could go to the next slide. So our current guidelines, just like all guidelines, are always in flux. And we have all different organizations that make recommendations. We have the ACG, who sponsor these slides, the American College of Gastroenterology. We follow recommendations from the American Cancer Society. But we also have a multi-society task force that kind of heads everything up and puts out our guidelines that we follow for our patients. And right now, those guidelines actually changed in October of this year, and basically said that we should start screening for average risk patients actually at the age of 45, not 50. Now, we're not all doing that, and the main reason for that is insurance reimbursements aren't doing that either. So in a perfect world, we would start screening at the age of 45 for everyone. So that's for lack of a better word, a soft recommendation. They firmly recommend starting at 50. So for the most part, we're still starting at 50. The exception is African Americans, and I'll talk about that again in another slide. But for normal risk individuals, we start screening. If they have a negative examination, if there are no polyps, then they're good for 10 years till they need any further screening, such as a colonoscopy. For patients who have polyps, the follow-up is closer. It's based on the number, size, and type of polyps. It varies in those patients. For patients who are at high risk, we start earlier. So the rule of thumb is for patients that have, for instance, a family history of colon cancer, we start at the age of 40 or 10 years before their family member was diagnosed. And those patients are followed at least every 5 years after their initial examination. And here we're talking about colonoscopy. I'll talk a little bit about some other tests in a minute. But African Americans should definitely start at the age of 45. And if you could go on to the next slide. We know that African Americans are being diagnosed with colorectal cancer at a younger age than other ethnic and racial groups. And also they have more advanced disease than other patients and other ethnic and racial groups. And therefore, the guidelines have been lowered to 45 for African Americans, and we're trying to hold to that. Next slide. So what other tests do we have? We have to have other options for patients, especially in this time when patients are hesitant to come forward and have screening, or may not have the means to do so. Well, this is probably not the best example of an alternative, but the only reason I put it in is we're getting asked questions about this all the time, and this is the so-called virtual colonoscopy or CT colonography. I use this occasionally. I probably have ordered maybe 6 within the last year and a half or 2 years. The main stumbling block is, again, insurance and reimbursement. They're not approved by many insurances. It's not a good first step, but it does have a niche, and that is in patients who we do exams on, who we may not be able to complete an exam. They may have a stricture within the colon or obstructing lesion. We sometimes will order these afterwards to look at the more proximal colon. And I have had these approved, but usually it requires peer-to-peer and a lot of extra work. But it does have some drawbacks. One is even in the best centers, smaller polyps less than 6 millimeters can be missed. It's not without discomfort, but it is some alternatives in some patients. Next slide. So this is the one I get the most questions about, and you would think that gastroenterologists might not favor this test, but to be honest with you, I think this is somewhat of a godsend, especially at this time that we're dealing with. So fecal stool DNA test is a test that's done on a single stool specimen, and here in the United States it's coupled with a FIT test, which is a fecal immunochemical test, and it's known as Cologuard for the most part. So it's sent to the patient. They do one valve movement. It's pretty easy to follow, and it tests for a gene mutation, also some biomarkers, genetic biomarkers, and as I mentioned, it tests for blood. It has advantages. It has disadvantages. The advantages are there's so many people now that would otherwise not do anything are doing this test. And when it's positive, we're seeing people come forward and get screened. The downside is it's not perfect. There are patients, if you look at patients who are positive for a fecal DNA test, out of 100 patients, supposedly 4% or 4 would have a colon cancer, 20% have advanced adenomas, 31% have adenomas that are less than a centimeter, and 45% are negative. So you have actually a 45% false positive rate. But still, these patients are coming forward and doing a test that they otherwise would do nothing. And when I was in training, the thing that was driven home to me was the worst thing that can happen is a patient leaving your office after you counsel them and doing nothing.
Right.
So if you can get a patient to come through and get screening in some way, especially something that's relatively easy like this, it's worthwhile. And we'll talk a little bit about, I think, COVID as it relates to all this stuff a little bit later in our talk. But that's basically it as far as our screening is concerned right now. We had a lot of delays, and we're starting to catch up now, so we're pretty busy catching up with people that missed their exams and people that are due now.
I have a quick question for you.
Sure.
What about those patients who prefer to use the fecal occult blood testing cards?
Well, I have a bias. I like the FIT test more than the guaiac. Mm-hmm. And the reason for that is the FIT test is one stool. It's easy to do. You don't have to change your diet or medications, whereas the guaiac's a little harder for patients to do. It's better than doing nothing, that's for sure. But it's 3 separate stools. You're supposed to modify your diet, which patients have a hard time doing. They do say that you can stay on aspirin when you do that test now. So if you could get them to do one or the other, that's fine. But I kind of have a preference for FIT just because of compliance.
Right. All right. Thank you so much. Okay. The next question I have is for Dr. Mantell. So do women who've had a hysterectomy, do they need to have pap smears done?
Okay, thanks for having me on the board. The answer to that depends on a few things. One, when women have their uterus removed, more and more nowadays, they choose to keep their cervix. And there are certain criteria for whether you allow a patient to keep their cervix or not. There are some advantages to doing that. So if they have a cervix, obviously they still need to have pap smears. If they've had their cervix removed, which is a total hysterectomy, then it depends on why their cervix was removed. If they have a history of pre-malignant cells prior to the removal of the cervix, or if they had cervical or uterine cancer, then they still need to have pap smears.
Okay. And at what age would they have to stop getting pap smears if they still have their cervix in?
That's a great question. Usually it's about age 65. That's assuming that they didn't have abnormal pap smears prior to that. Okay, and the other thing, getting back when I was listening to Dr. Stewart, when he was talking about how some things we would like to do, but they're not being covered by insurance.
Right.
Actually, in gynecology, it's just the opposite, because the recommendations for pap smears are that from 21 to 29 years of age, that we do cytology, which is just gathering the cells and having them looked at, and it's every 3 years. From age 30 until age 64, if the cytology is the only thing being done, then it's also every 3 years. But if they have high-risk human papillomavirus testing alone, or with cytology, it's every 5 years. And I can tell you I don't know any gynecologist that follows those guidelines, because insurance companies cover pap smear every year.
Right.
And even patients who are Medicare age, they cover them every 2 years. I mean, I don't think any of us are really comfortable with doing
5 years.
5 years. Yeah. And because we see in practice, especially if patients have 3 of the particular 14 high-risk strains, types 16, 18, and 45, which are the most virulent ones of HPV, we see patients who travel the road of abnormal cells to cancer a lot faster than what's recommended.
Okay, thank you.
Sure.
All right, I'm going to ask you another question.
Okay.
So, what's the difference between a traditional 2D versus a newer 3D mammogram, and who should consider getting a 3D mammogram?
Okay. So 3D mammograms have been around, I'm just guessing, probably around the last 4 or 5 years. The traditional 2D mammogram is basically taking a two-dimensional picture of a three-dimensional organ, and that carries an inherent problem with it. One, there may be little things throughout a woman's breast, and when you only look at it from one view, those two little things might sit on top of each other, and it may look like it's a mass, when in fact there's no mass at all. Obviously, when they do traditional 2D mammograms, they take different angles, but each picture is just one still picture. The three-dimensional mammogram, which is like a CAT scan of the breast, it's taking, the machine moves in an arc around the breast and takes several still shots, and then the computer software creates a three-dimensional image so that if there's anything that's artifactual, it can be eliminated, and the radiologist can actually look at any single slice individually. So if each slice is just a few millimeters wide, so they can actually see if indeed that's overlay artifact or if it indeed is a mass. And as far as who should be getting 3D mammograms, and you say, well, you might say, well, what's the downside to it? Well, the cost is a little bit more, but when they first started doing them, patients had to pay $50 extra. Now they don't. The other thing is it uses about 8% more radiation than a 2D. When we get mammogram reports back, they always report the woman's breast density. And breast density has to do with what percentage of the breast tissue is dense. And the categories are A, B, C, and D. C and D are dense. D is over 75% of the breast tissue is dense. C is from 50 to 74%. Those women are recommended to have 3D mammograms. In addition, if the woman is at high risk for breast cancer based on previous biopsies or if she has family history of breast cancer, then it's recommended that she consider 3D.
Okay. So then why would the 3D not preclude further evaluation by ultrasound if it's so much better?
It actually, because ultrasound is used mostly to see if things are cystic or solid.
Okay.
They're not as sensitive for detecting the breast cancer as either a 2D or a 3D. So they use that in conjunction with mammography, not instead of.
Okay. Thank you. And then the other question I have for you now is, should women at high risk for breast cancer do anything other than annual mammograms and self-breast exams?
Yes. First, another thing that's reported on mammogram reports is the lifetime risk for breast cancer for that particular patient. And the interesting thing about that is, in my area, all the radiology centers use different formulas. There are different models. The original one was called a Gale model. There's another one called Tyrocusic, which is very good, and there's another one called the Klaus model. And they all use different factors to determine the lifetime risk for breast cancer. But if the breast cancer risk is over 20%, then it's recommended that the woman has a mammogram and then a breast MRI 6 months later, and then alternating every 6 months between MRI and mammogram. The other thing, upon taking family history, some women are candidates for genetic cancer screening. A lot of people have heard of the BRCA mutation, BRCA1 and 2. There are actually a whole bunch of genes that increase risk. BRCA happens to be the highest risk mutation. It's about 87% chance of breast cancer by the time you're 70 years of age. So that's pretty close to 100%. So patients who have significant family history, and there are questionnaires that give the criteria of who should be genetically screened, and they should be offered that. And I personally think that should be standard of care, and it's not, but it should be.
Okay, thank you so much for that answer. So how do you reassure young women coming in saying, my grandmother had breast cancer? Do you focus on that particular part of the family history, or are you more concerned about first-degree family members?
Right. Good question. Actually, first and second degree is what we use. And with certain cancers, like breast cancer, it has to be under age 50. Or if there are 3 members in the family with breast cancer on the same side of the family, it doesn't matter. As far as ovarian cancer, if there's a first or second degree relative to ovarian cancer, then it doesn't matter what age.
Good.
And the other thing is the endometrial cancer, and this goes along with Lynch syndrome, Dr. Stewart had mentioned, colon cancer, endometrial cancer, and then there's some other cancers, there's several other ones that have a smaller percentage, but those things are tested for also. And I have patients with Lynch syndrome, and I work with their gastroenterologist because, from what I understand, Dr. Stewart could correct me if I'm wrong, I think if they have Lynch syndrome, they're supposed to have a colonoscopy every year.
Okay. Thank you so much for your answers.
Sure.
So I'm going to go back to the other side and talk to Dr. Stewart about what's happening with screenings with the new COVID crisis. So, Dr. Stewart, what impact has the current pandemic had on colorectal screening, and what are your current protocols for elective procedures as it relates to COVID-19?
Well, there's so much information coming out, so many statistics that you can read about the delay that we've had over the past, year since the pandemic began. It's hard to digest, no pun intended, all this information, but it's kind of scary. One of the studies that I did read looked at multiple states. I think there were 20-some states involved in the data collection, and over a 3-month period of time, there was a delay in diagnosis of 18,000 colon cancers. So they took a lot of this information, they try to extrapolate to see what does this mean in the future? What are we dealing with? And according to some of the current models, it looks like perhaps that we're going to have an uptick or an increase in morbidity and mortality of something like 11 to 12% of colon cancers over the next 3 years or so.
Wow.
So it's definitely affecting us, unfortunately, in a very negative way. So we're trying to catch up, as I mentioned earlier, with our screenings, and I think we're doing a pretty good job. But I think the take-home message in this is that, there are a lot of people who, they lost their jobs, they don't have health insurance anymore, or they're struggling to keep a business afloat. They don't have time to take out a day for a colonoscopy, or let alone in our practice, they have to take out a day and plus also get a COVID test 48 to 72 hours before their colonoscopy.
Mm-hmm.
So people, that's not on their high priority list right now. There are a lot of other things that they're dealing with. So I think that's where these other tests need to come into play. And other groups are doing things that are pretty inventive. They're sending out mass fit test screenings for free to patients in their communities to get back and try to catch up. So I think we have to be kind of inventive and try to, work around this curve a little bit and give patients other opportunities to get screened. We have this is even before COVID, we have for some of the underserved in the community, free fit testing, and anybody that's positive, the program provides a colonoscopy free of charge for those patients in underserved areas. So all these things come into play as far as our screening is concerned. But, hopefully, as I said, we can catch up and keep trying to do our best to keep this at bay. Our mortality rates and morbidity rates were going down up until this hit, unfortunately. So we have, protocols. I won't go into specifics, but not everybody does COVID testing before elective procedures. We've elected to continue to do that. Initially, we were doing COVID testing and making everybody self-quarantine for those couple days before their procedure. Now they do COVID testing, but they just have to follow face masks, social distancing, and those types of things. But just our day-to-day jobs are so much different. I mean, it takes us a lot longer to do the same number of procedures because of what we have to do in between procedures. And the breakdown, the cleaning of the rooms, the TPEs, it's all different. And, I don't know when that's going to change. We just have to continue to be careful and make sure our patients are as safe as they can be, because a lot of our patients, as I mentioned earlier, still are hesitant to come out and have screening or get exposed. So, but that's where we're at right now.
And that's very unfortunate because, like you said, the morbidity and mortality is significantly increased. And by them not coming in for their time-sensitive screening, it impacts their lives.
Yeah.
That's scary.
Yep.
Yeah.
Yeah.
Okay. So how do you manage to reach out to your patients who are due for screening and are somewhat resistant? What do you do in the interval? Are you one of those docs sending out the FIT test to them, or how are you managing that bridge?
Well, we have, unfortunately, in our EMR, we have kind of a tickler file system where people get reminders ahead of time. And as they're coming back to, and we actually had to hire, we have 3 schedulers now instead of 2, because the schedulers, now their job is even greater than it was before, because they have to go through a whole litany of questions just to get people scheduled. But in that process, they also have to be offered alternatives. So people are put into different boxes. Some people are going to come back within, a month or 2 and tell us what they want to do. Some people are getting FIT tested. Some people, we don't want to wait. They're urgent electives. They had a large flat adenoma removed within the past 6 months, and we need to go back and take a look at that site. So we're trying to fit people into different boxes and accommodate them and give them alternatives.
Thank you so much for answering my questions. All right, then we're going to go back to Dr. Mantell, and we're going to ask him, who should we consider for genetic cancer screening and for GYN and other cancer screenings?
Okay. Every patient that we see for their annual exam, and I don't give this form until a woman is 24 years of age. I'll tell you why in a minute. We give them a form to fill out, and there's about a dozen questions on there related to their family history of cancers. To give you a few, up at the top we have if the member of your family had breast cancer and they're an Ashkenazi Jewish descent, and they have breast cancer under age 50, that qualifies. There's a high penetrance of BRCA mutation in the Ashkenazi Jewish population. As I said before, any other person who was under 50 with breast cancer, any male breast cancer in the family at any age, ovarian cancer at any age, endometrial or colon cancer, and again, there's a whole bunch of other ones, including glioblastoma, pancreatic cancer, prostate cancer. All of those can be tied in. They don't have the same percentage. And I probably am missing a few, but those are the main ones. Also, if the patient has 3 family members on the same side with breast cancer, any age, or if they have triple negative cancer in the family. That's triple negative meaning that they don't have the receptors for breast cancer. Right.
Okay, you cut out for the last thing you said.
Yeah, I was going to say, I meant to say this is important. The reason that I don't give the forms until they're 24 is because if you test someone younger than that and they find out they have a mutation, there's absolutely nothing they're going to do about it at a younger age. The protocol is that if you do have a mutation, let's say a BRCA mutation, that at age 25 you start mammography, alternating with MRI every 6 months. Okay. One of the choices that patients have is to have bilateral mastectomy. And I actually have a patient of mine whose mother had breast cancer twice in her 20s. And when you hear of someone having breast cancer in her 20s, the red flag goes up because it's most often a mutation. Well, the patient of mine was 24, we tested her and she was positive. And when her mother came to the consultation, I said to her, I don't know if you're aware, but I'm not your gynecologist. I know you had a double mastectomy, but if you still have your teeth and ovaries, they should be removed. The risk of ovarian cancer doesn't kick in until after 35. So after women finish their family, the recommendation is to have a laparoscopic bilateral supplementorectomy, taking out the tubes and ovaries. And the other thing about that, it's interesting, we now, whenever we do hysterectomies, we take out fallopian tubes because there's a lot of evidence of ovarian cancer actually starts in the fallopian tubes. But as far as the other options the patient have is to have preventative surgery. And some women choose to have their ovaries removed but not their breasts. So then they get the MRI and the mammogram every 6 months.
Okay. Excellent. Thank you so much for that. So I heard that we have 2 questions in the chat. So student Dr. Cetinkaya, can you tell us what those questions are?
Yes, of course. So one of them is actually for Dr. Mantell, asking for when screening for women who have a family history of ovarian cancer, do you do annual transvaginal ultrasound and a CA-125 or just a TVUS alone?
Actually, I do more than that. That's a wonderful question, by the way. There is no protocol set forth by the American College of OBGYN or ACOOG, which is the Osteopathic College, what you do to screen for ovarian cancer because we don't have any great tests. So I kind of made up my own protocol. I get a transvaginal ultrasound every 6 months because ovarian cancer spreads so rapidly. Doing it once a year, I don't think is enough. It's too long of a time interval. And I don't do a CA-125 because it is not specific and it is not sensitive enough. Now, there are benign conditions that elevate a CA-125, and there are some ovarian cancers that do not. I use an OVA1, and if you're not familiar with OVA1, it's actually a proprietary test that only Quest Laboratories offers. It has 5 hormonal markers. CA-125 is one of them, and it has high specificity and sensitivity. It's a much better test. It's not approved as a screening tool. I think it will be very quickly down the road. It's used for someone who has an ovarian mass, and we need to know who's taking it out, the general gynecologist or the GYN oncologist. So the result, if the OVA1 is abnormal, then we send them to the GYN oncologist. But my own protocol is to do transvaginal ultrasound every 6 months and an OVA1 every 6 months to a year. So that test will probably not be covered by insurance because it's being used for a different reason. It used to be $800 or $900. Now it's about $200, $250.
Thank you for that answer, because that was my next question. How much does this cost, and does the insurance company cover it?
So all of these tests, by the way, have come down. When Myriad Labs was the first test to do genetic testing with BRCA, it's been over 30 years, they were charging $5,600 to do Lynch syndrome and hereditary breast and ovarian cancer screening. They're down to $1,800 because there are labs that will do it for $250 cash.
Wow. Okay, young student doctor, what's the next question?
This one was asked during when you were presenting the annual checkup, asking about if we still need to consider total pack years and age such as 55 to 79 during the annual checkups. I'm guessing in regards to the pack years.
Yeah, interestingly, pack year of smoking and getting a low dose CT doesn't necessarily allow you to have that low dose CAT scan. Because I had a young patient, he was 30 years old, started smoking at some abnormal age of 10 or 11 or something. So had a high pack year history. I requested a CT test. The insurance denied it. So I think that when we talk about screening, we may have to also include a chest X-ray PA lateral as a fallback for screening for lung cancer in patients with high pack year histories. So it depends. I mean, it's definitely been recommended highly by the Pulmonary Association. The first word is not in my head right now, but it's highly recommended, but it's not necessarily going to be paid for by your insurance company, and many patients are not willing to go out of pocket for this.
Thank you so much for that. No, I think that's all the questions that we have for tonight. Thank you so much.
Can I make one more comment, Dr. Phipps?
Yes.
When you presented your mammography recommendations, just like Dr. Stewart had said, there's many different organizations with different recommendations. And the task force, with 50 years starting mammograms, and I think it said sooner if.
Yes.
Yeah. I don't know any gynecologist that follows that or radiologist who recommends it. We see so many women in their 40s with breast cancer that the American College of OB/GYN recommends 40 years. And yearly after that, and that's what most of us do. So,
thank you for that clarification.
Sure.
And if I may interrupt all of you beautiful people, so I wanted to introduce myself. I'm Dr. Ekrem Cetinkaya, and in light of the time, I want to respect everyone's time who attended. I'm the chair of the RowanSOM Webinar Advisory Committee. I'm a pulmonologist and sleep specialist and alumnus of RowanSOM. I want to thank everyone for attending this evening's webinar. We thought it was appropriate to start the new year with this topic to help folks improve their health and start new and healthier beginnings. And I think you guys did a wonderful job in what rich material you covered, and I think you've helped a lot of people, so I really appreciate that. We hope that this session was helpful to all of you who participated and provided some guidance to help in the care of your patients and your loved ones. Now note that the recording of this session, for anybody who may have missed it, will be posted on our RowanSOM alumni page by next week. Please feel free to forward it to anyone in your circle who may benefit from this very important discussion. A very special thank you to my little sis, Dr. Virginia Phipps, Dr. Mantell, Dr. Stewart, and student Dr. Ekrem Cetinkaya. Thank you so much for your time and for sharing your expertise on this important topic. Many thanks to our Alumni Webinar Advisory Committee. In particular, a shout out to Dean Michichi, who does amazing behind the scenes work, never gets really enough credit. Gail Foreman, who was not able to be with us, get well too, Gail. We love you, miss you, and get back here. There's a lot of work to do. Nora Casper and Brittany Quintana, thank you so much for your multiple contributions. This webinar series has been an important new community resource for our school and our community, and we are appreciative for the support from so many to help bring this series to you. Now, the Webinar Advisory Committee is very busy planning programming for this year and proud to announce our next alumni webinar at this time. And I'm very proud to say I will be part of that next webinar. Please join us and save the date for Wednesday, February 17th at 7:30 p.m., where we'll address the state of the COVID-19 pandemic and the vaccination rollout more specifically. We hope to provide some important updates and insights from our experts. We will serve on this panel along with Dr. Joshua Corin, who leads the Vaccine Center at RowanSOM, and Dr. Janaki Shah, an infectious disease from Milwaukee. More information for this webinar will follow in your email, so please look out for that, but save the date, February 17th. I also want to remind our attendees to keep up to date with happenings, news, and programs for the Rowan University School of Osteopathic Medicine. Please like our Facebook and follow our Instagram at RowanSOM Students and Alumni. Let me close by thanking our panel once again and thanking all of you for spending part of your evening with us. Please stay safe and have a good night. Take care, everyone.
Thank you.